recurrent urinary tract infection in females. I would like to begin the talk with a practical case vignette which we see day in and day out, and this patient actually came to me a month back. So she was a 25-year-old female who presents with recurrent UTI. She had 3 culture-proven urinary tract infections in the last 6 months. Each episode occurred 1 to 2 days after sexual intercourse. She experiences so she experiences dysuria, urgency, and the same organism, that is E. coli, has been isolated each time in the culture. No other medical problems. She is not on any OCPs, but she uses condoms with spermicides. Examination is unremarkable. So this is suggestive of a post-coital urinary tract infection. So I discussed about giving her a post-coital antibiotic prophylaxis. I gave her an antibiotic, that is nitrofurantoin 100 mg single dose after each intercourse, and I advise some behavioral therapy, that is void after each intercourse, avoid spermicides, and I gave her a standing prescription of a 3 course of trimethoprim sulfamethoxazole as a self-start therapy if she develops UTI despite prophylaxis, but obviously after having sent a urine culture. Over the next few months, she has used this post-coital prophylaxis consistently, and she's had only one UTI, only one breakthrough UTI. So overall, she was very pleased with the reduction of infections, and I plan to continue prophylaxis for another 6 months. So this is how, if you can understand the pathophysiology of the UTI in that particular age group of the woman, and you can apply both pharmacological and non-pharmacological management, you will absolutely get good results. So UTI is actually the inflammatory response of the urothelium to bacterial invasion. It is in women, it is 17 times more frequent than men. Why? Of the short urethra. The lower 1/3 urethra is continually contaminated with pathogens from the vagina and from the rectum. Women do not tend to empty the bladder as completely as men, and they are exposed to bacteria during the contact also. So recurrent UTI is defined by the International Infection Disease Association as at least 2 episodes of UTI occurring within 6 months, or at least 3 episodes within a 12-month period. This can include cystitis or even upper urinary tract infections, that is pyelonephritis, though recurrent pyelonephritis is usually due to a complicating systemic factor like diabetes or like any structural disease of the kidney or the urinary tract. So recurrent UTI is a major health issue, and it can cause significant healthcare burden and cost, affecting women of all ages and backgrounds. This negatively impacts the both quality of life and contribute to indiscriminate antibiotic use and increases the antibiotic resistance in the community. So we know that the host defense mechanisms are due to multifactorial, and regular urine flow flushes out the bacteria. So incomplete bladder emptying can predispose to UTI. Also, the urine's chemistry, that is the acidic pH and the high urea and the osmolarity, are usually resistant to bacterial growth. Also, there is the urine with inhibitors of bacterial adhesion, that is lactoferrin, Tam horsol protein, that is uromodulin. These are natural inhibitors of the urine of the bacterial growth. Then there is a exfoliation of the infected uroepithelial cells, and of course the innate immunity, that is a TLR and the other things, they inhibit urinary microorganisms proliferation. To add to this, you have the mucosal immunity, which is contributed by the secretory IgA, which is secreted by the bladder and the urethral epithelium. And they have an innate immune response, that is the toll-like receptors that detect bacteria and trigger cytokines and neutrophils. The urothelium can shed the infected cells, and the bladder produces the important productive molecules, which I've already told you. Now, in the vaginal microbiome in premenopausal women, the estrogen promotes a lactobacillus dominant vaginal flora. Lactobacillus produces lactic acid, which maintains a low vaginal pH, which inhibits uropathogens. So this colonization resistance helps prevent UTI. What happens after menopause? There is a estrogen deficiency causes less of lactobacillus, so a higher vaginal pH. So the uropathogens, they colonize the vagina and they can easily translocate to the urothelial tract, and then they cause recurrent UTI in postmenopausal women. So 50 to 80% of women, this is the magnitude of the problem in general population, have at least one UTI during the lifetime. Most common is cystitis. Of those who have a UTI, 20 to 40% will have a recurrence and 25 to 50% will have multiple recurrences. Cystitis is temporarily related to recent sexual intercourse with a 60-fold increase in the relative odds of acute cystitis in the 48 hours after intercourse. Other risk factors are decreased water intake, reduced frequency of voiding, sexual intercourse, poor menstrual hygiene, poor personal hygiene, unsanitary menstruation practice, and of course, systemic diseases like diabetes mellitus and pregnancy. So remember that pyelonephritis in a young, healthy women, the predisposing risk factors we've already discussed, and sexually active women are more prone to the UTI because of the short urethra, proximity to the anus, and urethral trauma during intercourse. Now, during pregnancy, we all know that there is a physiological dilatation of the ureter and the renal pelvis due to the gravid uterus, and there is stasis of the urine. There is incompetence of the vesico-urethral valves, and there are a lot of hormonal changes that causes urinary stasis. In healthy postmenopausal women, lack of the estrogen, pelvic prolapse, less of lactobacilli, and increased periurethral colonization by the E. coli, higher rates of incontinence and medical illnesses like diabetes mellitus causes more UTI in the postmenopausal women. Now, what is the microbiology of UTI? The uropathogenic E. coli is a leading cause of UTI, responsible for both initial and recurrent infections. Other gram-negative bacilli like Klebsiella, like Proteus, Enterobacterial species are less common culprits. The gram-positive bacteria like Staphylococcus saprophyticus, they can cause UTI in younger women, and Enterococcus and occasionally Streptococcus can cause UTI in other species. Now, to understand this, we know that uropathogens have adhesins, that is type 1 fimbriae and FimH adhesin binding the uroplectin and the fimbriae binding kidney epithelium. So they attach to the urinary tract epithelium, and this is the first step in colonization and infection. They often originate from the patient's own intestinal flora. So just remember, it is the fecal, perineal, urethral route. Now, other etiological agents, we have already discussed, it is a gram-negative bacilli where the E. coli plays the major role. Others like Proteus, Klebsiella have a less common role. And gram-positive cocci can also cause UTI, especially in younger females and elderly females also. Now, what is a pathophysiology of recurrence? Please remember, most UTI occur via an ascending route. So, bacteria from the gut colonize the periurethral area and then they ascend into the urethra and then they ascend into the bladder. The anatomy of the women facilitates this route. From the bladder, the organism can ascend into the ureter to the kidney, causing pyelonephritis, but hematogenous spread is rare except in organisms like Staph aureus. So here we see it is actually the colonization in the periurethral area. Then they ascend in the urethra. They penetrate the uroepithelium, ascend into the bladder. From the bladder, they ascend into the ureter, and there they again cause colonization. With the help of the fimbriae, they quickly and they ascend into the kidney, and then they can cause pyelonephritis. Of course, do remember that bacterial toxins may play a role in inhibiting the peristalsis as well. So they also cause reduction in the flow of urine. And the fimbriae and the bacterial toxins are very, very important and help them to replicate here and may cause a biofilm as well. And this biofilm formation is very important for them to recur again and again. As I told you, that bacteria can form intracellular bacterial communities, that is IBCs, and the UPEC, for example, invades the urothelial cells. and replicates inside, forming biofilm like pods that shelter the bacteria from antibiotics. These can later disperse, seeding new infection. And IBCs also explain that why some patients have UTI symptoms, but initial cultures are negative because it is these intracellular bacterial communities, they are hidden inside the cell, and that is why they are more resistant to antibiotics, and antibiotic penetration is very poor. Now, if the infection is by the same strain shortly after treatment due to persistence, that is called as a relapse. And if it's a new infection by a newer strain, it's a reinfection. So, relapse is by the same strain of bacteria, reinfection is by a different strain. Please remember, majority of women are reinfectious from the fecal reservoir, but relapse can occur if a focus of infection isn't eradicated due to improper termination of antibiotic therapy or due to antibiotic resistance. But distinguishing between them is very, very important. If it is the infection is in a female with a structurally and functionally normal urinary tract, so there is no vesicular reflux, there is no bladder outlet obstruction in form of a stricture, it's an uncomplicated UTI. But if there is a vesico-ureteric reflux, if there is a bladder outlet obstruction, if there is a polycystic kidney disease, that will cause a complicated UTI. Clinical presentation of acute cystitis, we all know it's dysuria, increased frequency, urgency, suprapubic pain, malodorous urine, and even hematuria, even frank hematuria can occur. Usually, fever is absent in acute cystitis. Pyelonephritis, that is, the infection has involved the kidney, the patient will present to you with fever, chills, loin pain, lower urinary tract symptoms, sense of systemic not well being, nausea, and vomiting. Please remember.
Dr. Vivek, can you summarize it in 1 or 2 slides?
Yeah, ma'am.
Okay, thank you. Sorry.
No, it's fine, ma'am. So we must diagnostically evaluate it by a urine analysis. Urine culture is, of course, the gold standard for diagnosis. And we must differentiate between asymptomatic bacteriuria, where there are no symptoms, but there is a culture proven growth of a bacteria, simple cystitis, and complicated UTI. Please remember that all the international guidelines recommend against treating asymptomatic bacteriuria only except in three important patient populations. Number one, in pregnant women. Number two, kidney transplant recipients. And number three, people undergoing invasive urological intervention. Only in these three patients, you've got to treat asymptomatic bacteriuria. In rest of the patients, you may not treat them. In cases of recurrent UTI, you've got to investigate further. What is that? You have got to do, you've got to see the red flags or unusual clinical course. You've got to do an imaging like a CT or an ultrasound, cystoscopy, and other investigations like a MCU may be important, but you've got to delineate from the history and from these tests. If there are recurrent pyelonephritis, rule out stone, obstruction, anatomical abnormalities. If there is hematuria, do a cystoscopy. If there is a stone, do a CT urogram, and so on and so forth. How to manage these patients? Acute episode, treat with first line antibiotics like nitrofurantoin, cotrimoxazole, fosfomycin. Avoid fluoroquinolones. Of course, antibiotic stewardship is very important. Give short duration of antibiotics of 3 to 5 days and don't treat asymptomatic bacteriuria. Now, whom should you give antibiotic prophylaxis? Those patients who have frequent recurrences but who have a significant impact in their life. That is, it is disturbing their behavior, it is disturbing their mental peace, and they have risk factors as well. So, how do you treat them? You give them a antibiotic prophylaxis, that is nitrofurantoin 100 milligram once daily at bedtime, or cotrimoxazole or cefalexin. Post-coital prophylaxis is given a single dose after coitus. This prophylaxis is usually given 3 to 6 months for 3 to 6 months. Other behavioral measures, that is, and other non-pharmacological measures, that is, cranberry juice, have shown no RCTs have they been shown to be beneficial. Methenamine hippurate still undergoing use with caution in CKD. Estrogen, topical estrogen in postmenopausal women is very, very important, reduces the increases lactobacillus growth, and is said to be very, very important. Other things like D-mannose, probiotics have still have very limited evidence. Coming to the vaccines, last point, ma'am. Vaccines for recurrent UTI is the next big thing. We already have the Eurovaxome, the Eurovac, EXPC4V, and the FIMH vaccines. Most of them are still under trials, but they have very promising results. They are still adjunct or investigational, but in the next decade or so, I'm pretty sure that vaccines for recurrent UTI will be available for use in the market. So the take home message is obviously avoid unnecessary antibiotic treatment, stress on the behavioral measure, find out any treatable cause, and cater your treatment and tailor your treatment to the patient. For example, a young female must be given postcoital prophylaxis, and elderly women must be given vaginal estrogen therapy, and so on and so forth. Thank you very much.